This case is one of a baby with recurrent apnea in whom aEEG monitoring was particularly helpful. First, I want to note that I have received honorary and travel expenses from NATIS in the past, but I am receiving no compensation for this activity. Our case is of a term baby, a newborn male, who was transferred to our NICU at a few hours of age for respiratory distress and apnea. The history is notable for the following factors. It's a primiparous mother who was induced at term for pregnancy-induced hypertension, but pregnancy was otherwise uncomplicated. She was GBS negative. Her labor was prolonged with rupture of membranes for 28 hours. Although the fluid was clear, she did have a low-grade temperature during labor, which may have been due to epidural analgesia, but she was also given a single dose of ANSEF because of concern that there might be a low-grade infection. Ultimately, she had a cesarean section for failure to progress, and the baby looked good at birth. It was appropriate for gestational age and had EPGARs of 8 and 8. He required oxygen from birth, however, with mild grunting and tachypnea. So, because of the prolonged rupture of membranes, the physician at the delivery hospital obtained a blood culture and a CBC and started him on antibiotics. After a few hours, though, he developed apnea, and so transfer to our NICU was arranged. When our transport team arrived, they witnessed another episode of apnea, so he was started on CPAP, and that seemed to correct the apnea for the remainder of day 1. When he arrived in our NICU, he had a normal neurological exam. His CBC results were back. They were normal, and his blood culture ultimately was negative. A chemistry profile was notable for a low sodium and magnesium and elevated liver function tests, but those steadily improved after day 1. As did his respiratory status. He weaned off his CPAP to room air later on day 1. On day 2, however, he developed apnea again. This was mild until day 3 when it became more severe, and at that point we resumed nasocannula oxygen. We were concerned again for the possibility of infection and obtained an LP. We only got a scant amount of fluid, but we did send it for herpes PCR, which ultimately was negative. Also in our differential for recurrent apnea in a term newborn was seizures. So we started aEEG monitoring and immediately saw seizure activity, and we'll have the screenshot for that on the next slide. He was given phenobarbital 20 milligrams per kilogram IV twice before the apnea was controlled, and after that, total loading dose of 40 milligrams per kilogram. Seizures resolved on the aEEG, but later in the day, when a full montage EEG was obtained, additional seizure activity was noted, so he also was given a loading dose of phenytoin. Here's what the aEEG monitor showed us when his apnea was becoming a problem again. First of all, you'll notice that the time frame for this is that it happened shortly after midnight, so it was very helpful to have aEEG available at the bedside. And you'll see that on the left side there are recurrent seizures. I think most people would consider this to be status epilepticus. He did not correct with a single loading dose of phenobarbital, so he got a second, and after that had a pattern that was at least discontinuous, and I think if you look at the grayscale feature, you may say this is probably more consistent even with burst suppression. On the right side, it's a pretty normal tracing. It does look a little more irregular than you might expect for a continuous EEG, but I think it meets criteria for continuous before the phenobarbital, and then after the phenobarb, there are some periods of discontinuity, but that almost looks like cycling. So pretty normal appearance on the right side. His apnea and seizures were controlled after his loading doses of phenobarbital and phenytoin. He was left on a phenobarbital maintenance, and did not have further seizures after that first night of problems. His MRI showed a middle cerebral artery infarct on the right. Remember that his primary seizure focus by EEG was on the left, but the infarct was on the right with significant areas of restricted diffusion. There was a small area of hemorrhage in the left periventricular white matter, but that was the only change we could identify on the left side. He did improve clinically, was weaned off all respiratory support at 5 days of age. We got a repeat EEG at a week of age just before he was discharged, which still showed some sharp transients, left greater than right, but no seizure activity. So the role of aEEG in this infant is, first of all, that it helped us establish the diagnosis of seizures and show a response to therapy in the middle of the night, in a way that would have been difficult with any other technology, and certainly was not clinically easy to discern. It was notable by aEEG that seizures were much more frequent electrographically, in fact, probably status epilepticus, than would have been apparent clinically with his occasional episodes of apnea. And because we were able to make this diagnosis of seizures rather than go down a road of thinking that this was some sort of infection, we were able to say this was neurological injury and then subsequently show the underlying cerebral infarct and hemorrhage in a child for whom the history was not suggestive of a brain injury at all. So in summary, I think seizures should be included in the differential diagnosis of apnea in any late preterm or term infants for whom it could not be explained on the basis of prematurity. Second, the diagnosis can usually be established or excluded pretty quickly with the use of aEEG, which helps get therapy started and allows us to pursue other diagnostic procedures more quickly. And then finally, just a matter of some curiosity is that sometimes the aEEG or full montage EEG abnormalities can be more prominent in the opposite side, the contralateral side, to where the more notable MRI findings are. And that's our case. Thank you.